applications that they use for clinical information storage and so forth, but for the most part, not so much. So they're really bewildered by the number of choices and trying to understand what's necessary. And it doesn't help that when the final rule for meaningful use dropped, that it was 866 pages long. You know, no physician has the time or the energy to read and absorb all of that. I've only read through it once, end to end, and this is my business. And you know, I'm just waiting to regenerate a few brain cells before I try to read it again. Because it's not all legalese, but it's fairly technically oriented. So these physician practices are sitting at ground zero, and most of all, what they want is someone that they can trust and develop a relationship with so they can navigate this wild field they're in right now. The other thing that makes it very difficult to be an ambulatory physician is the whole, coming back to what I said a few minutes ago about fee-for-service. It's very, very difficult to stay in business in a fee-for-service model. However, the alternative to fee-for-service is pay-for-performance or Medicare Advantage. And that is a completely different model for physicians. It has to do with risk management. They're compensated in a completely different way. And they actually have to learn some differences in coding the procedures and coordinating diagnosis codes. Now, that is where we're headed. The HITECH Act looks like it is all about technology, but the reality is for 5 years, 6 years down the road, the goal of HITECH is to have improved outcomes, healthcare outcomes, and to have a patient-centered medical home so that we have a high level of care coordination. And Health IT is just the mechanism to that end. So this whole notion of moving to a risk management where I'm going to get compensated, I mean, right now I know if I see, you know, an established patient and I have a follow-up visit that's scheduled for 15 minutes and I tie it to the appropriate diagnosis code that the Medicare, the vanilla Medicare schedule is going to pay me $37.50 for that interaction. But if I move to pay for performance or Medicare Advantage, then suddenly I've got a different schedule. If I've got a patient with diabetes type 2 and suddenly I add coronary artery disease to it, then I've got a whole new, that turns into a completely different animal and a completely different fee schedule. So it's very, very daunting, but this is all what you are potentially stepping into. Just makes it a good time to become a trusted advisor to a physician. So what I've done is to put together for you a blueprint process, and there is a blueprint tool that goes along with this. It is not quite ready for prime time, but it will be available in the fall. It is going to be part of a foundations program that CompTIA is presenting. But I'm going to tell you about the blueprint process and then a little bit about the tool towards the end of the presentation so you can see how it's put together. It's based on how we work directly with physician practices. And let me just step back for a second and tell you, we are consultants. We are not resellers. We don't sell software, hardware, or anything else. We are vendor agnostic. We have relationships with many, many vendors, and we are not opinion agnostic. We have some very strong opinions about what good software is and what good software is not. However, we consider the physicians to be our clients, so we present a completely neutral face and we help them make their own decision. Consequently, we don't even accept referral revenue from software vendors. So that's kind of our orientation. We work directly with doctors and we want to be their trusted advisor over a long period of time. So this is how we work. It works for us. I think it'll work for you as well. Basically, you want to start out by capturing the basic demographics around the practice. Who are they? What's their address? What's their legal structure and how they're known? You'd be amazed how many physician practices are operating under DBAs, multiple DBAs sometimes. What's their specialty? Who are the owners? How many locations do they have? Understand a lot about their staffing, how many doctors, how many mid-level clinicals and clinicians, and don't ever call them that, and I'll explain why a little bit later. How many nurses, how many billing and administrative staff, and so forth. And that staffing information is really important not only for you to understand how to sell into this practice, but that's the way, particularly if you're selling an application that's going to be delivered as software as a service, that's how it's going to figure into pricing. When were they established? Are they using an EMR or EHR product currently? Not long ago there was a survey where doctors self-reported their level of usage of EHR software, and 40% of them said, yes, we use EHR software. Well, I got to tell you, the reality is closer to about 8%. And a lot of those 40% that reported really are using practice management software. And all practice management software does is manage the appointment desk and the examining rooms across multiple offices and across multiple clinicians. So that is not an EHR, which must, by definition, have a clinical information system module as part of it. So the level of uptake is not huge. But you do need to know what they're using currently, because you may find yourself in a position where they don't want to give up their practice management software, and so you're looking at the pros and cons of trying to interface with an existing product. Ask them what they like and don't like about it. Cost for value. You want to record the source of the lead, at least I do, because it's really important for me to know where my business is coming from. Did it come to me? Did I go to them? Did I have an event that generated this lead? Was it a referral from an existing client, and so forth, so that I can track my effectiveness on the marketing side as well. So all of this should be captured sort of in one centralized area, and the toolkit I'll show you has a place for that. And this is what you use as the basic platform for preparing to make that first call, and which will hopefully culminate in a face-to-face visit with the physician or the practice administrator. When you look at specialties, there's probably nothing more important that you need to ask the practice than to understand what their specialty is, because the way work flows through an individual specialty is wildly different depending on what it is that they do. A dermatology practice, the workflow is completely different from what you see in a pediatrician's office, from what you see in a cardiology practice, and so forth. So that is very, very important to know. Also, inherent in some of these systems are some quality reporting features that will be specific to specialties. So you start out there, and basically what you want to know is, are we dealing with a primary care practice, a surgical practice, or some other specialty? And as I said before, under primary care, you're going to find your internists, your board-certified internal medicine practitioners, family practice, OB/GYNs, and pediatricians. Now, more and more often, I'm seeing OB/GYNs moving sort of out of the primary care role, and that's just a function of living in a litigious society. If there is an issue that is anything less than well woman or anything other than a gynecological or obstetrical issue, they are very likely now to refer a patient over to an internist or another specialist to take care of that particular issue. But I still would put them in the category of a primary care physician, because for most young women who are healthy and of childbearing age, that's normally who they see every year. Under surgery, there are a variety of different subspecialties, and then the other specialties that we'll see as well. For the basis, from the standpoint of a primary care physician and what they need from an EMR, EHR product, and oh, by the way, you may have heard this already, but I get this question all the time. What's the difference between an EMR, electronic medical record, and an EHR, an electronic health record? An electronic medical record software product is designed to be used within a single enterprise, a clinic, a hospital, a doctor's office. An EHR product has been functionally designed to be exchanged. And so what we're seeing, and the certification requirements for 2011 certification for usage is an EHR as opposed to an EMR, which is unfortunate, because if you try to type in EHR, spell check will immediately change it to HER. H-E-R. And I hope you don't see this in this presentation, because it seems like every time you open a file, it'll respell EHR into H-E-R. I hope I've scrubbed that down. But what they need, with primary care, you never know what you're going to see. And this is another challenge that those physicians find themselves facing every day. It's very difficult for them to try to triage their patients. So if I'm a physician and I'm working with maybe one other doctor in my practice, I'm an internist, and I have maybe a nurse practitioner and a couple of physician's assistants, the best use of my mid-level clinicals is to see the low-risk, sort of recurring patient load. But you don't know what you're going to see when a patient comes in. So sometimes it's very, very difficult, and you end up with the mid-level having to bring in, run physically and get the MD or the DO, if you're in a state where osteopaths practice, and bring them into the actual physical examination. So you don't know what you're going to find there. So you need a wide variety of symptomological or disease-based templates so that they're not building from scratch. They have the ability to go in and say, I'm going to open an upper respiratory infection template because that's the chief complaint that the physician is presented with, that the patient has presented it with today, and that's going to give me a range of symptoms like nasal congestion, headache, cough, nasal discharge, and so forth. But they need one of everything, one from column A and column B, because they don't know what they're going to see on a given day. Pediatricians not only need that, but they need growth charts and immunization features as well, because that's a big part of what needs to be tracked within a pediatrician's EHR. The growth chart element is a requirement for meaningful use. They have to be capturing that data, as is immunization information. OBGYNs, on the other hand, need a product that has the ability to interface with a sonogram or a fetal monitor, which are devices that they frequently use within their office because everybody wants to hear the baby's heartbeat the first time. They like to be able to do in-office sonograms as opposed to referring out. So they need a product that gives them the capability to capture those images or that data and bring it into the EHR, either as structured data or at the very least as a document, a PDF of some sort. For primary care docs, they need a lot of robustness in the area of social and family history because that really concerns them. They're treating the whole person for a long period of time as opposed to a specialist who in most cases is seeing an acute issue that has a beginning, a middle, and an end. Primary care docs want to see you and want to know you as a patient for many, many, many years. So knowing about whether there is a history of heart disease, a history of alcoholism, a history of diabetes, and so forth is very important. And lots of these doctors, in my experience, will spend an extended amount of time in that first new patient appointment documenting this kind of information. And then, of course, e-prescribing and electronic lab interfaces are also requirements of meaningful use, although there's no requirement to transmit lab data electronically in stage 1 or 2011 and 2012. But the e-prescribing is a requirement. And the ability to do that electronically has huge benefits for a primary care practice because their front desk people take an inordinate amount of calls every day, calling in for refills, pharmacies calling for refills, making referrals around lab work, getting lab work results in, and so forth. So that's a place where when you go in to talk to a primary care physician, you can demonstrate a significant return on investment for that practice. When you look at the surgical specialties, there are any number of subspecialties under surgery, but I've pulled out the ones that have peculiar needs and the ones that you will tend to see most often. Not that some other physicians don't do some level of in-office surgery. Certainly, in some cases, dermatologists and primary care physicians do excisions of cancerous growths and so forth. But for the most part, surgery happens here. You've got general surgeons that take on anything that involves an invasive procedure. Hand surgery is a specific specialty. Head and neck surgery, neurology or neurological surgery, orthopods, plastic surgery, thoracic surgery, and vascular surgeons. And it's good to remember that cosmetic surgery is not a board-certified practice. There are some practitioners that do that, but a board-certified physician in that specialty is specifically a plastic surgeon. They all have very specific needs. For these kinds of surgeons, general, head, neck, neurological, and thoracic, almost all of their procedures happen in the hospital. Although as medical technology moves along, we are seeing more and more endoscopic surgeries. But for the most part, these guys do their basic bread and butter work within an OR and an inpatient setting. So for doctors, surgeons in these specialties, they need software that makes rounding easy for them. And let me explain what that means.